Sounds good. Great. We'll go through. There you go. You got it. Good.
At this point, I'm going to mute my
Yeah, I'll
audio. If
talk.
you guys need
I'll talk.
something from
Yep.
me, just let me know.
Yep. Good morning, everyone. As you join this morning's talk, we're going to start in a couple minutes. My name's Alex Kaur. The others on the panel are our speakers, Shani Levany from Israel and Dr. Barry Feig from Houston, Texas, will have closing remarks. As you join, this picture that you're seeing on your computer is kind of the famous Auschwitz liberation picture. And my mom and my aunt are at the front, and Shani's grandmother, who actually is sitting next to Shani, as Shani's pointing at her, and then her grandmother's twin is to her, to Shani's immediate right, and then the arrows pointing at Shani's great grandmother, who was ironically friends with my grandmother. So it's definitely a unique um, um, picture, and we were all together at Auschwitz for a medical ethics conference in October of 2022. So, but we'll get started here shortly. Give it about 3 or 4 more minutes and we'll get rolling here. As you listen to today's talk, feel free to send in the chat room questions. And at the end of the talk, we have a few questions that we're going to ask Shani, and then the questions that you ask in the chat room will then be presented to Shani, and then we'll have concluding remarks from Dr. Barry Feig. Maybe 2 more minutes here and we'll get rolling. Give more people a chance to get admitted. Okay, I think we'll go ahead and get started. Got about 20 some people. So good morning. My name is Dr. Alex Kaur. I'm a podiatrist here in Indiana. And also I'm the son of Eva and Mickey Kaur. As I mentioned earlier, this picture is a very important picture. It's the Auschwitz liberation picture. I'm pointing at my mom and my aunt, and our speaker, Shani Levany, who I'll introduce in 1 second, is pointing at her grandmother, who also is sitting next to her. But her grandmother and her grandmother's sister were also Mengele twins, and the arrow in the back is her great-grandmother, who I mentioned earlier was friends with my grandmother. Today's top talk is what my grandmother taught me about humanistic medicine, reflecting on my legacy as a granddaughter of an Auschwitz twin survivor while practicing medicine. And first, I want to say thank you to Shani Levany. Shani is in Israel, and as we discussed earlier, is in the midst of completing her master's degree in public health, has completed medical school, and will be starting her residency in pediatrics. She also was involved as a appointed leader of the Student Advisory Council, which she'll mention. And I want to say one thing that I really appreciate her taking the time. And as I said, the schedule will be that she'll talk for about 45 minutes. Then we have a few questions, and then please feel free again to in the chat room drop us questions, and that will be how we end the discussion. And then some closing remarks by Dr. Barry Feig, who is a retired surgical oncologist from MD Anderson in Houston, Texas. So without further ado, I turn it over to Shani, and thank you all for listening, and I hope we get some good questions. So thank you very much, Shani. It's all yours.
Thank you, Alex, for the introduction. I'm very excited to have this webinar today. It is a great honor for me to have the chance to speak with all of you. This webinar has been long in the making, and I am very, very glad to finally give it and to do it so close to the marking of the International Holocaust Memorial Day, which was about a week ago, is even more exciting. And before I begin, I'd like to thank Alex and Barry and the whole Kendall's Museum staff for putting this webinar together. And even though Alex gave me a great introduction, and the flyer for this webinar makes it quite clear, and the headline of the lecture is even clearer, I would still like to state what are my credentials in the field of medicine and the Holocaust. And so for 5 years now, I've been the TA / co-director of the course Medicine's Reflections in the Holocaust, which I teach in my university, the Goldman School, a medical school at Ben-Gurion University of the Negev. I am also the assistant to the Lancet Commission on Medicine, Nazism, and the Holocaust, and the head of the Student Advisory Council of the Commission. But above all, as Alex said, the reason this topic is so important to me personally is that my grandmother Leah, her twin sister Judith, and their mother Rosie were all subject of medical experiments in Auschwitz. As far as I see it, medicine and the Holocaust is my family's story. It's my legacy, and learning and teaching it are my ways to have a closure and to maybe help heal some of the wounds my family carries. And I have the utmost honor to have my grandmother here with me today. She will say hi, but she's very shy, so she won't be part of it entirely. So just, this is my grandmother Leah, and she's very excited to be here as well. Okay, so what will we talk about today, and what are the goals of this webinar? This one won't be a lecture about the history of medicine, Nazism, and the Holocaust itself. And my main goal today is to convince you that it is important to learn medicine, Nazism, and the Holocaust, regardless of your training level, discipline, religion, nationality, or a personal connection to the Holocaust. And I will be doing it by using my own story, my own relationship with my grandmother. It will be kind of a case report in which I am the case. But before I can make my case and share with you the lessons my grandmother taught me of humanistic medicine and how to be a better physician, I'd like to address the question of why learn about medicine, Nazism, and the Holocaust to begin with. And the most often asked question I get from medical students taking my course and medical professionals I give introduction lectures to is what history get to do with healthcare. And I answer that by using two questions. And the first is, why is medical history an important part of anamnesis taking? And how does it affect the patient's care? And the answers, I hope, are clear to everyone here who practice any kind of healthcare. Medical history is important because it has a huge treatment changing and even life-changing effects on the patient. For example, if my patient had an allergic reaction to penicillin in the past, I would not prescribe amoxicillin to treat their current pneumonia. And now I ask you to think of healthcare professions as a patient. If we want to improve the health of the profession, shouldn't we know its history? What went wrong in the past? What are the conditions we are treating? And when I say health of the profession, I mean it in the broadest sense possible. The profession is not just the registered practicing personnel treating patients directly. It's the healthcare education students, residents, and even certified experts receive. It's the local and global healthcare system. It's the policy, how it is made and how it is implemented. It's the relations between this discipline and politics in a domestic point of view and global point of view, and so on. And as far as I see it, if we want to improve any aspect of our profession, of course, everyone in their own scope and ability, we need to know the history of the profession because it affects the treatment we need to give. So what history got to do with healthcare? Everything. Now, let's assume that my a bit simplified analogy managed to convince you that knowing the history of our profession is important. Why learn about medicine, Nazism, and the Holocaust, and not about other historically relevant events? What makes this history unique or better suited for the mission of healing the profession? And I'd like to answer that with another analogy. So let's say I'm a GP and on a certain day I see two patients. The first is a young male, usually healthy, no chronic diseases. He's not using any kind of medication. He doesn't have any significant medical conditions in his family. And he complains of high fever for the last 3 days, cough and some breathing discomfort, which were preceded by a week of rhinorrhea. On my examination, I hear crackles with decreased breathing sounds matching in location to the right lower lobe. And I diagnose him with pneumonia and prescribe antibiotics for a week. And I'd like to ask you, how long will this kind of appointment be? 10 minutes from the moment he steps in to the moment he leaves? Maybe less if it's a patient I already know and I'm familiar with his medical history. So in this case, what role or effect his medical history had on the way I cared for him? Probably not much. It helped me to rule out some more serious differential diagnosis. It helped me decide on the appropriate treatment. But generally, it mostly helped me to understand that the hoofbeats that I'm hearing are really horses and that there's no need to consider zebras. Now, the other patient I see that day is a 60 years old lady. She has been diagnosed with lupus for 30 years now. She had many exacerbations over the years and was treated with oral steroids many times to the point she developed diabetes at 45 years old. Her disease had many manifestations over the years, APLA with PE and CVAs, joint involvement, alopecia, distinctive rashes, spondylitis, ocular disturbances, and so on. She went through multiple treatment lines, and over the last year, she hasn't been symptoms-free, and her condition wasn't controlled. And she complains of high fever for the last 3 days, with cough and some breathing discomfort, and this was preceded by a week of rhinorrhea. On my examination, I hear crackles with decreased breathing sounds matching in location to the right lower lobe. And what will my diagnosis be? Will I be as quick as I was with the first patient and diagnose her with simple pneumonia? Will I refer her to ancillary tests like blood tests or chest X-ray? How long will this kind of appointment be? Will it also be 10 minutes from the moment she steps in to the moment she leaves? How much longer will this appointment be if it's her first time at my clinic and I need to take all of that medical history? And what role or effect her medical history have on the way I need to care for her? And I hope that the answer is obvious, that the effect is a big one. Her medical history here makes some very serious, yet usually not probable differential diagnosis a real possibility in this case. Can it be acute lupus pneumonitis? Maybe she has pleural effusion. Maybe it is pneumonia, but because of her medications, she is immunocompromised and it is not a common pathogen causing this pneumonia. Her medical history dramatically affects the way I need to care for her and manage her symptoms. Every bit of her medical history changes and shapes the management and the diagnosable possibility of her condition, current condition. And we all know how lupus can affect almost any system or organ in the body. So the medical history, her medical history, makes the hoofbeats that I'm hearing more likely to be zebras or even unicorns than horses. So what these two patients have to do with reasons to learn the history of medicine, Nazism, and the Holocaust? If previously I said the patient's history affects the treatment, it's important to know, and healthcare professions are analogous to patients in a way. Now I'm adding to that, and I want to claim that different medical histories have different effects on the patient's management and how we are informed by them. Some histories have an acute effect, some have chronic effect, some have many effects, and some have scars. Some rule out differential diagnosis and some rule them in. And in the same way, some of the histories of the medical and healthcare professions affect the way we practice medicine more extensively, while other histories have a more modest effect on our practice. Now, I wouldn't be so audacious to claim that the history of medicine, Nazism, and the Holocaust has more significant effects on our practice than other histories of the profession. Or, well, I wouldn't do that without some evidence. As I introduced myself, I've been the head of the Student Advisory Council to the Lancet Commission on Medicine, Nazism, and the Holocaust for the last 3 years. And the Student Advisory Council, the SAC from now on, was assembled with the notion of adding a diverse and young perspective to the commission. The SAC members are from various healthcare professions such as medicine, nursing, bioethics, public health, and neurosciences. We have members representing wide range of countries: Austria, Canada, Cyprus, Germany, Greece, India, Indonesia, Israel, Japan, Kenya, Spain, and the US. And over the course of our collaboration, we met once a month to expand our knowledge, to discuss questions asked by the commissioners, to discuss our perspective and opinions on the commission's work, to work on creating a wider understanding of the relevance of medicine, Nazism, and the Holocaust education in different regions of the world, and to help each other develop local education programs. And what I find as the most unique part of this experience for me is the realization of how something that is very personal to me can also speak to others with non-inferior impact. When I started to work with the SAC, I was already teaching medicine, Nazism, and the Holocaust in my medical school. And in my classroom, it wasn't a unique experience when my students had a personal connection and interest in this history. My students were mostly Jewish, some even third generation to survivors, and could obviously understand it is not improbable for them to treat survivors at one point or another. And moreover, there's a certain ethos to the Holocaust in Israel. It's almost like a living entity. Almost everyone learns about it in high school, in elementary school. There's, of course, the 2-minute commemoration siren every Hebrew Holocaust Memorial Day. And it's a sort of shared social sensitivity. So why was I surprised with the interest by the SAC members? There are some obvious answers, such as they are not all Jewish, not Israeli, it doesn't concern them, and more of this kind of notions. But once I reflected on my surprise, I understood that I wasn't supposed to be surprised. I was already teaching my students mostly very universal lessons. None of the main morals I tried to teach my students required them to be descendant of survivors or Israeli or Jewish. The only requirements were for them to be part of the healthcare community and to be interested in forming a professional identity that is beneficial for their future patients. So why wouldn't it impact students around the world, regardless of their nationality, ethnicity, religion? And on November 9th, 2023, just 3 months ago, the Commission launched its report, and together with the SAC, I had the honor of publishing a comment in the Lancet about the Commission's report. And while the report calls for teaching of medicine, Nazism, and the Holocaust, in our comment, we chose to focus on why to learn it. And I'd like to tell you a bit about a few of the points we made to support the call to learn this history. And as I already reflected on, the core ethical transgressions and the morals to learn from these transgressions are relevant regardless of nationality, religion, race, ethnicity, or gender. It's not a secret that ethics courses are not students' favorite, and medicine and the Holocaust studies reframe ethics in a more real way. It's less theoretical, more practical study of ethics. And one of the ways it reframes ethics studies is by compelling the learner to focus on decision-making processes and not specific details of moral dilemmas. It's because the specifics of these dilemmas are so extreme that it makes it obvious to the learner that they won't encounter the exact same situation. So there's no need to memorize the details. And it leaves more room to learn from the process of decision-making. The understanding of your power as a physician and of your ability to cause harm comes rather late for most. As a rule, I think it's safe to say most practitioners studying medicine or any kind of healthcare profession with the notion they will help others. No one comes to these professions with a desire to cause harm, but harm is part of the nature of our power dynamics with our patients. And only when we acknowledge our ability to cause harm, we can try to prevent it. The history of medicine, Nazism, and the Holocaust provides ample examples of the abuse of power with the notion of doing good while actually doing evil. The complexity and the longitudinal prevailing nature of the Nazi crimes and other medically crimes of that time cannot be dealt with without a profound critical thinking. The rhetoric of the Nazis was so distorted that if you don't approach it with criticism, you will be left confused and torn. And with all the bad that one can learn from this history, there's also good to be learned. There are courageous physicians who stood up for their patients, who resisted, who were true to the purpose of the profession, and they teach us of our moral duties. They show us what we need to do and not just what we don't need to do. So these are the main reasons I choose to acknowledge. These are the main points I choose to acknowledge today, but there are more reasons to learn medicine, Nazism, and the Holocaust, and they are described in the SAC's comment to the report and are discussed in the report itself. So far, I gave you physician-friendly analogies to why I learned medicine, Nazism, and the Holocaust, and I told you about the SAC and what we did. But this lecture was supposed to be about the lessons I learned from my grandmother and from reflecting on my legacy and how these lessons and this legacy impacted my practice. But before I further dive into that, I need to explain two concepts I will be using. And they are called echoes and reflections. And beside the poetic ring of it, there's the obvious by name association to the Roman story or mythology of Echo and Narcissus. The nymph Echo falls in love with Narcissus, but can't speak with him because he was cursed and can only repeat the last words of what others say. And when they meet at last, he rejects her because he is disgusted with her weird trait of only repeating what he said. And then a different goddess punishes him to fall in love with an unreciprocating love object. This leads him to fall in love with his own reflection in the pond, a reflection he does not recognize as his own. And then they both kind of waste away, he while looking at his reflection and she while echoing the words of love he speaks to his reflection. And I think most of you see where I'm going with these metaphors, with this story. But these are not just metaphors for me. These are actual learning tools I use while I learn and teach about medicine, Nazism, and the Holocaust. And echoes is my metaphor for the resemblance between past and current events. And just like actual echoes, they are not exactly like their not exactly like the original sound they echo. And I strive to not be like Narcissus and Echo herself. I'd like to be able to recognize echoes as echoes. That means I don't expect to encounter situations identical to events during the times of Nazism and the Holocaust. But I can encounter a situation that will remind me of this history and can inform me and can inform my actions while also distinguishing the differences between the events. And I try to recognize echoes of the past in my present because once I'm aware of these echoes, I can make my own choices. I would not act through autopilot. Reflections is my metaphor for the ability to see ourselves clearly, bad and good, to be critical of what we see. And moreover, the reflection we see depends on the mirror and the lenses we are using. So one must always scrutinize the mirror and the lenses and ask, is it a distorting kind of mirror? Do I wear pink lenses, making everything look peaches, and so on. And while reflection is a known healthcare educational tool, and the Commission's report expands quite a lot about it, I use this metaphor in a broader sense. As an educational tool, reflection is a retrospective tool, but I try to use it as a prospective and even, let's call it, real-time spective tool. I try to bring the reflection, or rather the mental object I use for reflecting, I try to bring them with me into practice. So instead of reflecting back on an experience that is done, I try to reflect on my actions as I go. I don't want to look back on my actions and think, oh, well, I wish I acted differently. I want to be able to correct myself in real time and to prevent harm, or at least rectify my mistakes in real time rather than trying to deal with its aftermath later. And I'll go more into how I do it a bit later. And how everything I talked about so far comes together. And this is the moment I believe you've all been waiting for, which I'm going to talk about what my grandmother taught me about humanistic medicine. And for me, everything I talked about so far is influenced by my grandmother. I believe she is the reason I wanted to be a physician. She is why I was and am interested in learning medicine, Nazism, and the Holocaust. She is the reason why I took that course when I was a second-year med student. She's the reason why I became a member of the course staff. She's the reason why I teach it. She's the reason why I am giving this lecture now. And I knew she was afraid of doctors before I knew of the things Dr. Mengele did to her. And I decided to be a physician when I was about 5 years old, because I wanted to heal my grandmother's fear of doctors. And during the years, the image of the exemplary physician in my mind was formed around the idea of healing my grandmother's fear and around the question, what should a physician be like so my grandmother will not be afraid of them? And once I started my studies, this question kind of evolved into a few other questions, such as what should a physician be like so the patients will not be afraid of them? And what should a physician be like or do so their patients will feel comfortable and safe and seen with them? And the last question is a key question I use in my practice. It is my method to make better choices in real time and to correct myself in real time, to prevent harm or at least rectify it in real time rather than trying to deal with it later. And this question is sort of the mirror I inspect my reflection with. If I don't like what I see in the mirror, it means I need to make a change and I need to make it now. And I call these questions, and a few more I use, I call them ethical algorithms. And I activate these algorithms when I recognize echoes of certain events. The echoes make me aware of the need to use real-time reflection. And why don't I just use the simple tool of think of the patient as someone you love? It will be the easiest thing for me to do. I'll imagine every patient is my grandmother and will always be the most empathic physician I can be. So why don't I just do that? First, I do not believe it's sustainable in the long run. I believe it can lead to quicker burnout, and this will accomplish the exact opposite of what I want to accomplish. And well, there's a reason it is not ethical to treat your family members. So to think of every patient as a family member is not recommended. So the question, what should a physician be like or do so the patient will feel comfortable and safe and seen with them? It comes from my relationship with my grandmother, but it humanizes the patient that is in front of me in that exact moment. It acknowledges that the specific patient's wishes and feelings, and it is the key, in my opinion, to humanistic medicine, and that's something that my grandmother taught me. And I want to demonstrate what I am preaching, and I'm going to speak about the pink elephant in the room, which is the October 7 pogrom. And I'm going to stop the share screen for just a while. And I want to talk about what I experienced that day. So because October 7th was a holiday and a Shabbat, I was staying at my parents' house, which is about an hour and a half drive from the hospital I work in, the Soroka University Medical Center in Beersheba. And I woke up that day at 6:29 a.m. To the sound of the rocket alarm. We all ran to the safe room, stayed there for a bit, and then I went back to sleep because rockets being fired on civilian population in Israel is a matter of fact, sadly. And a couple of hours later, my mother wakes me up and says, Shani, something big is happening in southern Israel. I think you need to go help in Soroka. And not long after, I was racing myself. Well, actually, I was racing my car while rockets are flying above me to Soroka. And I did it because I knew that most of the injured will be brought there. It is the largest hospital in southern Israel, and it's a level 1 trauma center. So I knew we will receive most of the casualties. And the moment I entered the hospital's grounds, I discovered how little did I understand of what was going on. I've been studying and working in that hospital for 6 years, and I have never before seen the outer skirt of the hospital and its parking lots as packed as they were that day. There were cars parked on the sidewalks and on the lawns, and there was no place to fit in even a pair of bicycles, so let alone more cars. And some of the cars had bullet holes in them. They had shattered windows, even blood stains. And I changed into scrubs and went straight to the emergency room. And when I walked into the ER, I was hit by the ghastly smell of fire and smoke and burned flesh and blood. And that was the first time in many to come that the word Holocaust popped in my head. The smell reminded me of how Holocaust survivors have described the smell of the crematoria in Auschwitz and other death camps. And up to that moment, the echoes of the Holocaust weren't apparent to me. I understood that it was not an ordinary terror attack, that it was something in a scale we haven't seen yet in Israel, but no Holocaust echoes up to that point. And we all know it is not ordinary for Jewish people, let alone direct descendants of survivors, to call something, anything, no matter how bad it is, a Holocaust. Moreover, I avoid at all costs using what is called the Nazi card or the Holocaust card, or even simple comparisons to the Holocaust out of respect to the gravity of the Holocaust. So when I say that the word Holocaust surfaced in my mind, I do not say it lightly. I say it with humble intentions and with awe and reverence to the magnitude of this word. And this is why I refer to it as an echo and not as an actual Holocaust. The word Holocaust that kept surfacing in my mind and the echoes I felt calling to me made me aware of how this history was influencing me in the present, in that very ER. And going back to the ER, there were so many injured that the hallways were blocked and passing with a gurney was nearly impossible. People screaming in pain, crying from agony, wandering around lost in despair, looking relentlessly for their loved ones. And I was very aware of what I was doing at every moment because I recognized the echoes and activated my ethical algorithms. I finally understood the scale of what was happening, and I knew that in such an emergency, I want to have a choice in how I act and not just act instinctively. We are trained to follow flow charts and actions scans in emergency with the justified notion that it is how we save most lives. And this is actually how you don't freeze, but act. But no mass casualty action plan that I know of takes into account the in-between moments. When you move from one patient to the next, and on your way, a crying mother asks you if you have seen her son. or when a patient refuses to be taken to surgery because he lost his girlfriend in the rave, and he must know what happened to her. And in these kind of moments, I wanted to be aware of the choices I make, so I would be able to reflect on that day and say, I made my patients feel safe and seen. So when I drew blood from a young soldier covered in ashes, wearing uniform pants, but a PJ's top, I asked if she spoke with her parents yet. She said no, because she lost her cell phone. And I gave her my cell phone to use while I finished taking blood from her. And when I heard the young man in the bed next to the patient I treated next, saying he won't go to surgery until he finds his girlfriend, I told him to write down for me her name and his cell number, and to send me a picture of her, and that I will look for her while he is in surgery. And he was convinced and agreed to go to surgery at last. And just like I promised, every time I moved on to the next patient or task or ward, I kept my eyes peeled and looked for her. And when others noticed that what I was doing, they asked me to look for their loved ones as well. And at the end of that day, I had a list of names and a bunch of photos of strangers on my phone. And it wasn't much of a use, because I only found one person, the first girl on my list, the one who started it all. But for that couple, I think it made all the difference in the world. And when a baby needed someone to be with him until his aunt came to be with him because both of his parents were murdered, I didn't just watch him lay in his crib. I picked him up and I cuddled him and sang to him and soothed him, because I asked myself, what would make this baby feel safe? Even though he is not even 1 year old and I don't know what he will remember, I still ask myself, what will make him feel safe? And I did that because I wanted his aunt to know, when she came to pick him, I wanted her to know that we treated more than just his dehydration. We cared for his emotional needs as well. We tried to make him feel safe, and I wanted her to know that we did everything in our ability to care for her nephew in a very chaotic and surreal reality of both of his parents being murdered and him being alone in a hospital when he's only 9 months old. And these are just a few of the choices I made that day, a few acts that are answers to the question, what should I do so the person in front of me will feel comfortable and safe and seen. My actions were not informed just by the questions I asked myself, but also by what I learned from the history of medicine, Nazism, and the Holocaust. Through learning about this history and reflecting on it, I was much better prepared, even in the middle of a mass casualty event, because I had learned and thought of resource allocation, of showing compassion, of triage and prioritizing, of getting informed consent, of medical confidentiality, of primum non nocere, every day of my training. I was putting into practice all the ethical algorithms I have been developing through reflection. And I scaled the options I had in accordance with what I learned from reflecting on the way physicians handled very similar dilemmas they faced during the Holocaust. The questions I asked myself while practicing gave me a better understanding of the ethical and moral aspects of the situations I dealt with that day. My choices that they were informed by the recognition of the relevant echoes and were navigated by the ethical algorithms I developed for myself from the lessons my grandmother taught me about humanistic medicine and through reflecting on medicine, Nazism, and the Holocaust. Okay, so what my grandmother taught me about humanistic medicine, or why I learned about medicine, Nazism, and the Holocaust. When I think of why my grandmother fears physicians, I end up with the notion that she was betrayed by physicians that dehumanized her. And I think that that's what broke her trust with medicine and with healthcare professionals. And so humanistic medicine, I think, is about rebuilding the trust between patients and physicians and healthcare providers. It's about making the patients feel safe and seen. And because not every physician in the world is directly connected to a survivor of an unethical, cruel medical experiment, I think learning about medicine, Nazism, and the Holocaust is how one can learn the values of humanistic medicine regardless of if they are connected or not to survivors. Because the history of the profession is the history of the profession as a patient matters, and because this history is not lupus, this history is not pneumonia this history is lupus and not pneumonia in a healthy young man, and because its lessons are universal and they reframes ethics studies. They informs informs us of the ability to cause harm, and they promote critical thinking. And this history highlights our moral duties, and because the recognition of echoes informs us. And informs our choices, and because reflecting upon this history helps navigate difficult decisions. And I'd like to finish with a video of my two favorite women in the world, my grandmother, Leah, and her twin, Judith. I'm showing it at the end of my lecture because they sum up everything I just said, and they do it way better than I do in 5 minutes instead of 50 minutes. So if I had shown it at the beginning, my lecture would have been unnecessary. This was filmed a few days before October 7th, and it was filmed for the launch of the report by the Lancet Commission on Medicine, Nazism, and the Holocaust. It was filmed as a comment to the publication of the report, and it's in Hebrew, but there are subtitles, and I think it's an important video, so that's why I'm showing it, even though it's in Hebrew.
אנחנו נולדנו ב-1937 בשמלוס לבני, הונגריה, וב-1944 נכנסו הנאצים להונגריה, ואחרי לא תקופה ארוכה לקחו אותנו לגטו, שם היינו 4 שבועות. בתנאים מאוד קשים. מאוד קשים, בלי תנאים אנושיים. ומשם לקחו אותנו לקרונות, קרונות של בהמות, בלי אוכל, בלי מים, בלי תנאים.
בלי שירותים.
בלי שירותים, בלי שום דבר. אחרי 5 ימים הגענו לאושוויץ, הרכבת נעצרה.
הורידו אותנו עד 2 מהקרונות, ופתאום אנחנו ראינו בחוץ אנשים לבושים עם בגדים, עם פסים. אנחנו ירדנו למטה, בתוך שנייה נעשתה כאילו סלקציה, לקחו את כל האנשים, ואמא שמעה.
נפרדנו מהמשפחה, לא ראינו יותר את המשפחה. נשארנו רק עם אמא, אני...
בצד אחד, אני החזקתי את היד של אמא, בצד שני אחותי, ופתאום מישהו קרא צבילינגה, ואמא אמרה שיש פה תאומות, רצו להפריד בינינו ובין...
בא איזה אסס שהוא ממש רצה לקחת אותנו, התחלנו לבכות, אז הוא אמר, טוב, שנישאר עם אמא.
לקחו אותנו לצריף, איפה שכל אחד כאילו נהפכנו מאנשים למספרים. כל אחד קיבל מספר. למחרת לקחו אותנו למרפאה, ושם עשו לנו כל מיני בדיקות וזריקות.
והשוואות בין חלקי גוף.
בין אחד לשנייה. והכניסו אותנו לבלוק של התאומים.
כמעט כל יום לקחו אותנו
בא מנגלו או איזה
קצין אס-אס, ולקחו אותנו למרפאה, ושם המשיכו לעשות כל מיני ניסויים שנורא הכאיב לנו, והיה מאוד קשה, ולפעמים גם קיבלנו מכות, ומאוד מאוד פחדנו, וזה המשיך. למרות שפחדנו, כל הזמן באו ולקחו אותנו
והפחד הכי גדול שלנו היה, שראינו שהרבה תאומות שלקחו, חזר רק אחד, לא חזרו שניכם, ואנחנו נורא פחדנו שלא יעשו לאחד מאיתנו משהו, שאנחנו לא נוכל לחזור ביחד. חוץ מהפחד והזוועה, מה שעברנו שמה, שאנחנו לא רוצים להזכיר את זה, זה מאוד עזר לנו, עצם העובדה שיכולנו להחזיק ידיים וחיינו ביחד. אולי פיזית אנחנו לא רואים את כל הסבל והזוועה שמה שעברנו, אבל מצד שני יש לנו אי ביטחון, הרדות ופחד מהרופאים. אף אחד לא יכול לתאר לעצמו את הפחד מה שיש לי לגשת לרופא.
מאוד חשוב לי שאנחנו הולכים לרופא, שהרופא יחשוב על הפציינט.
אחרי המחרה נמצא בן אדם עם נשמה, שמי יודע מה הוא סוחב כל החיים שלו.
זה לא חשוב אם הוא היה בשואה או שלא היה בשואה. אף אחד לא יכול להבין את זה כמו שאנחנו מבינים את זה, כמה שחשוב להתחשב בתור בן אדם, לא רק בתור פציינט.
ואני מקווה שאחרי כל הדברים האלה היפים, מה שרואים שהדוח הזה נותן ושעושה, אף פעם עוד לא יקרו דברים מה שאנחנו עברנו.
So thank you for listening, and we will move on to Q&As.
Shani, that was a great talk. This is Barry Feig. Alex seems to have got disconnected. I think I hope somebody's working on getting him up there, getting Alex up there. Let me just pull up the questions I have them. I just didn't pull them up because I wasn't planning to be the one doing it, but I have them right here. So give me 2 seconds.
Barry, would you like me to start with the Q&A
No, I
from
have.
the chat while
With
you're
what? With what, Trent? Say
I
again?
can start with the Q&A from the chat while you're
No, I have the questions. I'm right here.
okay.
I'm ready. You ready, Shani? As Alex told everybody, my name is Barry Feig. I was a surgical oncologist at MD Anderson Cancer Center in Houston for 30 years, 35 years. I retired about a year ago. Obviously, working in cancer center and patients have only diagnosis as cancer. There's a lot of ethical issues come up, and that's why I've been very interested in this topic for a long time. Actually, that's not the right one. Send me the ones you have, Trent. I'm sorry, that's not the right question. Sorry.
That's okay. We just got Alex back, so
Oh, okay.
I'm back. So sorry about
Okay.
that.
Alex, just so
Shani,
you know where we're at, I was just about to ask Shani the first question, but I didn't have him pull him up because I wasn't
I'm
paying
good.
Okay, go ahead.
Yeah, sorry about that. I have no idea what happened. For those of you that Shani mentioned the Lancet Report Commission. If you have time today to watch the entire video, but one thing I did a little homework this morning. I listened to Richard Horton, the editor-in-chief, and two things that he mentioned really stuck with me as Shani was giving her remarks. One was we must remain human in inhumane times and conditions. And the other is that medicine is practiced today as if the Holocaust never happened. And I think for any of us in medicine, or any of us that have an interest in this, I think it's very important that we keep these in mind. So I encourage everybody to. I know there's a couple of questions, one or two questions in the chat room, but we'll go to the questions that we spoke about earlier. So Shani, in reference to perhaps the next pandemic or physician burnout, are there specific moral and ethical issues that we've learned about from the Holocaust that might help prepare the medical community, young doctors, old doctors like me and Barry for the next pandemic or for physician burnout? I know it's two separate questions, but I thought we'd start with that.
Well, I think that the COVID-19 pandemic taught us all a great lesson in humility, first of all. So do the lessons of medicine and the Holocaust. These are actually lessons in humility, if I kind of try to wrap it all up. And so the appliance of medicine, Nazism, and the Holocaust lessons for the purpose of preparing us to the next pandemic or the next global medical challenge that doesn't necessarily have to be another pandemic. And so I think there are a few levels of how these lessons are applying for that purpose. And of course, there's the personal level of forming a professional identity that sees the patient and not the disease. And I think that the lessons of medicine and the Holocaust are very influential for that purpose of creating moral resilience on the personal level of physicians and residents and students. And then there's the pre-planning of emergency action plans that can be also informed by this history. And there's the policy level that can also consider lessons from the Holocaust. And on each of these levels, you use different perspectives inside the big history of medicine and the Holocaust. But it can inform any of these stages, these levels. And in the note, like how it can help to prevent burnout. So once again, it has a lot of effect on building moral resilience and building professional identity that is not only beneficial for our patients, but beneficial for our mental health in a way. And just like I said it in the lecture, I don't imagine every patient as my grandmother, because it causes more burnout. But I ask myself questions that humanize the patients, all of my patients, and that's how I keep myself from burnout as well. I'm building compassion and empathy from internal resources that are not as likely to burn out as some other internal resources.
Very good. Very good. You mentioned empathy, and I encourage anybody to ask questions. We have maybe one or two right now. But a couple, 6, 8 months ago, I was giving a lecture to some residents in Chicago, similar topic, using my mom's experiences. And at the end of the lecture, one of the residents said, you know, Dr. Kaur, when I went into medicine, I was really, I wanted to help my fellow man. And now after being 4 years of medical school, I've become somewhat less empathetic. Now I'm in my residency and I just want to get through the end of the day. So my question is, which we talked about, and it's also mentioned in the Lancet report, you know, would you suggest that learning about the Holocaust helps medical students, young residents, show more empathy for their patients? And if so, why and how?
Okay, so the full name of the commission is the Lancet Commission on Medicine, Nazism, and the Holocaust: Historical Evidence, Implications for Today, and Teaching for Tomorrow. And it's important that the educator teaching this topic will stress the implications for today, because otherwise the learners will ask, how is this related to my present? And the goal of teaching empathy will be lost. So the first step, or the first thing you need to do in order for this history to teach empathy is to acknowledge how the implications are important for today. Because when a medical student comes up to me at the end of a lecture and asks, well, this was nice, but how is it related to my daily schedule? Or a resident comes up to me and say, well, how does this affect the 10 knee replacements I need to do tomorrow, and so on. So the first step is to stress what are the implications, and to put them in the center of the lecture or seminar or course or whatever. The center of the learning should be how we are implementing these lessons today. How can we be informed by them, and how can we be transformed by these lessons? And as I mentioned it in the lecture, I use the concepts of echoes and reflections as tools to bring the past into the present. I use these tools as methods to inform, form, and transform my professional identity and my actions. And I try to do it with my students as well. And I hope that the examples I gave from my experience on October 7th and how my actions that day were affected by the history of medicine and the Holocaust are enough to convince that this history is relevant for anyone's schedule for tomorrow. And because there are plenty of core dilemmas and conflicts between ethical concepts and this history, and there is a lot to learn from how positions dealt with these dilemmas in the past. I think that the dilemma that you mentioned, or the kind of problem we are dealing with, which is burnout, we can find examples in this history to inform burnout nowadays. And just on the matter of an overflowing schedule of too many surgeries for the next day, we can use the stories of Jewish physicians in ghettos and camps and learn from the way they decided who to treat and how to allocate the less than enough medications, and how they showed compassion even in the chaos of an overflowing hospital in the ghetto. And we can learn, of course, we won't encounter these exact situations, but we can learn from the process of decision making, how this physician decided to do that and not something else he could have done. Why? And this is how you connect everything. And on the other hand, we can take examples from Nazi position, who from them we can learn what was the process of dehumanization. When we say my schedule is too full tomorrow, I have 12 cataract surgeries or knee replacements or whatever to perform. Do we dehumanize our patients when we think of them as assignments to accomplish? Isn't it dehumanization? And of course, it's not on the same level. It's a different kind of dehumanization, but it is a sort of, and acknowledging it, and all other kind of problems we're facing, the acknowledgement is the way we deal with this, and we can learn how to acknowledge it by the history of medicine, Nazism, and the Holocaust.
Very good. I'm going to ask one more question, then I'll go to the chat room. There's a lot of comments and questions. How can an institution like Candles Holocaust Museum spread this message, spread your message? We have started a bioethics committee because of obviously the connection to Mengele's experiments and my mom and your grandmother. But I was just curious if you had any thoughts on how institutions like Candles can help.
So first, I'd like to point out that in the report by the Commission, there's specific part or section on place-based learning, and there's a lot of information of how we can educate our students using museums and all kind of public spaces to go, that we can go and visit, and especially a museum that is dedicated to the topic of the twin experiments and medical experiments as a whole. It's a great space for place-based learning. So, for example, the museum can create connections with healthcare professions, schools, medical schools, nursing schools, any kind of healthcare professionals, and schedule tours with a discussion at the end. They can, like, the tour can learn from the stories that are already presented at the museum, and you can also create a kind of traveling exhibitions, which will travel to schools that are far from the museum itself, or even you can take it outside of the US and kind of have a traveling exhibit in every place in the world, basically. And just even creating in-house programs that are specific to nursing schools, they are specific to medical education, they are specific to kind of giving a spotlight to specific dilemmas and specific concepts that need to be addressed.
Very good. I'm going to go, Shani, our chat room. There's a question from Vienna, Austria. Gregory Weeks, an historian. Substantial medical research conducted after the Shoah was based on previous Nazi experiments. How do we ethically address medical treatments that save lives but have their origins in earlier experiments that were conducted unethically? Tough question.
Yes, it is. Couple of I'll start with a side note. As far as I know, there's a small percentage of the Nazi medical experiments that was actually beneficial for medicine. It's for a lot of different reasons. Some of the experiments weren't even conducted in a scientifically way, and the part that was conducted in a scientifically means the questions that were asked were irrelevant for medicine. So as far as I know, not a lot of the data is relevant to save lives, but there's some experiment that did provide some kind of important data, and the data already exists. So I personally do not believe it will be ethical to not use it once it already exists. But you need to acknowledge the harm that was done while using it. You need to say, well, I am basing my current experiment on something that was done unethically back then, and this is how I am making my experiment ethical. That's one thing, and so there's the interesting question of how do we treat Nazi eponyms, diseases that are called after or named after Nazi positions, not necessarily on Nazi experiments, or maybe discoveries that were made before the Holocaust itself or the Nazi regime. But it's a very current question, which, again, this is just my opinion. I personally do not believe it's the right thing to do to kind of take down the names and give new names. I think that actually using the eponyms and referring, well, this person did that and that and that, is more educational and more ethical, because that's how we will do better. If we'll erase the history, if we'll erase the eponyms and say, well, this is a new disease and the past does not count, then we learned nothing.
Shani, Dr. Feig wants to jump in, and then he has another question as well. So
yes.
So, Shani, just to add my input, this is a huge area of controversy. It's going on fairly recently. It was increased fairly recently. I think you have to be very careful in using, if you're going to use any of this data, because even if it looks like it was done scientifically in a good scientific manner, obviously the baseline is it was done for the wrong reasons, or done for the wrong reasons. But we don't know if this data is really accurate. There are reports that people would just fill in the spaces so Mengele wouldn't get mad, or they make up data to make it look better. So you don't know that the results are, there's no quality control. There's no way to ever get quality control over it. So if you're going to use this data, you have to be really, really, really careful from a scientific standpoint, because it could be really inaccurate data, and it's very hard to quantify that. Where this has become a big question recently is the Pernkopf anatomic atlas was done by Nazis. And there were SS marks in some of the pictures on the original editions. Now, I've used the Pernkopf atlas years ago when I was in medical school. I never knew that, no clue. There's something that raises a dilemma where the atlas is there. You're looking at the pictures. There's no that wasn't fabricated data. That's just good. They are good pictures, and the question is, should we use that or not? And I don't think that's too big a topic to address here. But that's just an example of one type of thing that could potentially be used, when most of the data it would be very dangerous to use. And then the question was a question from the
what I said at the beginning, that as far as I know, most of the data is not applicable and is not usable in any kind of way. But the bit that it is need to be used in a conscious way.
Constructive. Yeah. So, Shani, one of the interesting things, I know, Alex, you may want to comment on this. Your mother had tried for a long time to get medical information about the medicines or whatever she received. Nobody has any detailed medicines, do they? Details of the medicines.
Of what was injected? No.
Yeah. No. So not a lot is known about most of the experience done in Auschwitz for two reasons. The first is that most of the physicians who worked there fled a few days or weeks earlier, and they took all the papers with them, and or they burned it or whatever. And the other reason is that the medical papers that were found in Auschwitz are believed to be archived in what is today's Russia, and these archives are not open to the public, and that's maybe some of the data is there, but we don't know for sure. But it was the Red Army that liberated Auschwitz, so they got all the papers that were still there. So not a lot is known.
Yeah, it's because that information could be helpful to an individual person's survivor's benefit. For example, if we talk about twins being perfect controls for each other, Alex has said this publicly. His aunt died of after she had malformed kidneys. They found she had a kidney transplant, and then died of bladder cancer. Well, how come your mom didn't have that? And so if they really have perfect controls, it's possible that your aunt's renal insufficiency and her bladder cancer were because of the experiments that were done on her. Because otherwise, your mother should have developed bladder cancer. So, and no twin is a one-for-one absolute perfect match. That the same thing happened, but it's just an interesting way to look at it. There's one question from the chat room that Alex asked me to ask, and it's from Anna Carson. Have you observed transgenerational medical impacts of the Holocaust?
I'm gonna speak for my family personally. As far as we know, we are not aware of any kind of medical impacts that were that passed on. But I do know that for some twins or some other survivors of medical experience, there were some kind of a generational passing of diseases, but it's very anecdotal, and we are not able to trace back to the experiments themselves. So that's all I can say with certainty.
Let me ask a very practical question. You know, you mentioned that you went into medicine specifically, or one of the reasons because of your grandmother's experiences. I can tell you from my perspective, like your grandmother, my mom hated going to the doctor to her dying day. And when I told her initially I was going to go into medicine, she wasn't so thrilled. So in regard to that, has your grandmother and your grandmother's sister, has your involvement in medicine helped them be less hesitant to go see their doctor?
I'm not sure about being hesitant to go and see their doctors, but I do know that my grandmother is very excited for me to be certified because, and this is a quote, "Now I won't have to go to any different doctor. I can just call you."
Very good. Well, we're drawn toward the close, Shani. I wanted to thank you. The comments in the chat room, there's some very interesting comments, and I thank everyone for their questions. If anybody, and I'll turn this over to Barry in a second, but if anybody has an interest in being involved in our bioethics committee, please contact me or contact Candles. We'd like to, you know, do similar programming and similar events. And Shani, I can't thank you enough. I know you put a lot of time, and I know this week wasn't an easy week for you. And please give your best to your sidekick there, your grandmother. And I'll turn it over to Barry and thank everybody for tuning in, and thank our staff at Candles for helping me out on the IT. And I apologize. I don't know what happened to my Wi-Fi there, but I'll let Barry have the last comments. And again, Shani, thank you very much. Toda Rabah.
Thank you, Shani. That was a superb talk, and it's really enlightening listening to people that have lived through, you're basically living through what your grandmother went through in your body, and it's really just amazing to see how you've incorporated it. And it's really, as everybody probably is aware, there's going to be a much more important issue in the next couple of years because of what's going on, all the unrest in the world right now. And one of the things that the Lancet Commission wants to do is to was to be sure that people were aware that no matter who you are, you should have you should voice your opinion. And if you see somebody how did the medical profession get dragged into this abyss of immoral and illegal behaviors? And we have to prevent that from happening. The best way is to make sure people know that it happened before. And we're not that far from it now. And in 2018, the journal Nature, which is number 1 or number 2 ranked journal in the world, issued a warning on the rise of anti-Semitism that was going on in the world, and nobody listened to them. And they have a pretty big audience. And what's happened? October 7th happened, and anti-Semitism has gone skyrocketed. So just because you're a scientist, or just because you're a teacher, or just because if you're not, just you don't have to be president of the United States to have, or president of Israel to have an impact, or to get people to open their eyes. And people were asleep at the wheel, and people need to wake up because there were people that were saying it. You can apply it to medicine too. There was there were things we learned from the Ebola virus that should have been transferred over to the COVID treatments, and people just ignored what happened in Ebola. There was an editorial written in the Atlantic magazine that basically outlined what they did wrong in Ebola and what should be done to prevent a pandemic from happening. And the guy basically predicted the future, because exactly what he said happened in the pandemic. So if we don't listen to our past and learn from our past, we're going to repeat the same things over again. They're going to come back and hit us even harder. So, keep your head up, and, if you see something that's wrong, say so. I really enjoyed this. Alex and I have been talking about this for years. It's nice to see it happen. I think there's so much more we could talk about. If you're interested, like as Alex said, please let us know. If you're interested in helping financially, these things, we can do bigger and better things if we have money. And I think Troy or Trent will have make sure anybody who's registered has a way to help get a hold of us in whatever they can help. So thank you all again. Have a great day.
Great. Bye-bye. Good night in Israel.
Thank you all.
Thank you, Shani.